A core claim driving enthusiasm for NR and NMN is their supposed superiority in delivering NAD, precursors directly to hard-to-reach tissues like the brain or deep into mitochondria, promising more targeted benefits for neurodegeneration or muscular aging. By contrast, niacin is often dismissed as limited to the liver or unable to raise NAD, where it's most needed. But is this distinction grounded in solid science, or is it a narrative outpacing the evidence? First, it's true that some rodent studies show NR and NMN can increase NAD levels in the central nervous system, CNS, when administered orally or intraperitoneally. These results have been widely cited to claim NR/NMN's superior CNS bioavailability. However, the data are far from clear-cut. Other studies in mice suggest that both NR and NMN can undergo rapid systemic conversion to nicotinamide, NEM, or other metabolites before crossing the blood-brain barrier, BBB, raising the possibility that much of the brain's increased NAD actually comes from circulating NEM or smaller metabolites rather than intact NR/NMN. This indirect pathway means niacin could, in theory, produce comparable CNS NAD elevations via systemic metabolism if plasma levels are sufficiently high. Adding to the uncertainty is that direct transport mechanisms for NMN across the BBB in humans remain unconfirmed. While the SLC12A8 transporter has been proposed in mice, its expression in human tissues, particularly the brain, is poorly characterized or absent, leaving it unclear whether NMN can reliably cross into the human CNS in meaningful amounts. For NR, evidence suggests it must first be metabolized into NEM or NMN before contributing to CNS NAD, again blurring the line between NR's distinct contribution and that of generic NAD. Precursors like NEM or niacin. By contrast, niacin's ability to raise systemic NAD has been unequivocally demonstrated in humans. Decades of clinical use show that niacin can increase NAD pools throughout the body, including red blood cells, and likely the CNS via circulating NEM or other intermediates. High-dose niacin, though limited by tolerability due to the flush, has been shown in animal models to elevate NAD in the brain and protect against neuronal injury, with some early human studies hinting at cognitive benefits, particularly in conditions like multiple sclerosis or neuroinflammation. This suggests niacin's apparent lack of CNS targeting may be more a reflection of historical underdosing or avoidance of higher doses due to the flush, rather than an inherent inability to impact brain NAD. Moreover, the assumption that NR/NMN inherently target mitochondria better than niacin also oversimplifies the reality of NAD dynamics. None of these molecules directly enter mitochondria. NAD itself cannot cross mitochondrial membranes, and mitochondrial NAD pools are regulated primarily by NADH/NAD shuttles, e.g., malate aspartate, and mitochondrial-specific biosynthesis from precursors like NMN produced within the mitochondrion. Therefore, boosting cytosolic NAD by any precursor, whether niacin, NR, or NMN, can indirectly influence mitochondrial NAD through these shuttles, but no evidence shows NR/NMN have privileged mitochondrial entry. Instead, what matters most for mitochondrial or cis NAD replenishment is achieving sufficiently high precursor levels systemically to support local NAD synthesis. In that respect, niacin's limitation is practical. Doses high enough to produce plasma levels on par with effective NR/NMN supplementation often cause intolerable flushing. Yet this is a solvable problem. With extended-release formulations, targeted prodrugs, or nanocarrier-based delivery systems already under exploration to control peak plasma levels, it's plausible that niacin could achieve tissue NAD restoration similar to or better than NR/NMN, but with lower cost and more reliable pharmacokinetics. Therefore, while NR/NMN's potential to enhance NAD in tissues like the brain or muscles is exciting, the current evidence doesn't robustly support that they possess unique or superior tissue targeting in humans. Much of the observed benefits may simply result from overall NAD elevation, achievable with niacin if tolerability barriers are overcome, rather than reflecting a fundamental inability of niacin to raise NAD. In key tissues, the assumption that only NR/NMN can do so stems from limited human data, aggressive marketing, and a lack of innovation in niacin delivery. Ultimately, niacin's proven systemic NAD boosting capacity combined with targeted delivery strategies, could unlock CNS and mitochondrial benefits comparable to or exceeding those of NR and NMN, without the cost or untested long-term safety of newer molecules. Recognizing this opens the door to affordable, effective NAD-centered interventions with niacin as a legitimate cornerstone, not an obsolete alternative.